Hello, everyone. Good morning or good afternoon, depending on where you're joining us today in the country. Today, we're going to get started with our webinar on screening for broadband access and digital literacy in public housing patients. And this is brought to you by the National Center for Health in Public Housing. So first, we're going to go over just a few housekeeping items. Just a reminder that all participants are muted upon entry. I believe that since this is a webinar, you may not be able to turn on your cameras, but if you are able to, please do so. Please make sure that you also engage in the chat. If you have any comments or any questions that you may have, raise your hand if you would also like to unmute. At the end of the presentation, we're going to be going over a Q&A session. And also, this webinar is being recorded, and the slides and the recording link will be sent via email within a week after today's session. So this is just a brief introduction about ourselves. For today's speaker, you have myself. My name is Filipina Sandoval, and I am the Training and Technical Assistance Manager here at NCHPH, and I will be helping moderate today's webinar. Then we have Kevin Michael Lombardi, who is the Director of Research Policy and Health Promotion, and Howard Chapman, who is the Director of Programs and Development at Tri-Area Community Health. They're going to provide their own brief introduction as well.
Hello, everyone. Dr. Kevin Lombardi. Background is a general internist and epidemiologist. My research focus is primarily on resource utilization in the emergency room and in improving health outcomes for those who are estranged from public services.
And I'm Howard Chapman. I've been working in community health centers in rural Southwest Virginia for 43 years now. I've done time as CFO, 28 years as CEO, and past probably 11 and a half years, I've been Director of Programs and Development at Tri-Area. Been involved in telemedicine since early 2000, so about 22 years for me.
Thank you so much, Howard, and thank you, Kevin. All right, so here's some information about the National Center for Health in Public Housing. The mission of NCHPH is to strengthen the capacity of federally funded public housing primary care health centers and other health center grantees by providing training and a range of technical assistance. Also at NCHPH, we're supported by HRSA, and we're also a national training and technical assistance partner and is 100% financed by this grant. This information or content are those of the author and don't officially provide a position or policy of, nor should any endorsements be inferred by HRSA, HHS, or the US government. So here we have just some brief background information about those health centers located in or immediately accessible to public housing. So first, there are over 1,300 federally qualified health centers that serve 30 million patients. There are also 458 FQHCs that are in or immediately accessible to public housing that serve to 5.7 million patients. And of those 458 FQHCs, there are 107 PHPCs that serve over 900,000 patients. In terms of public housing demographics, this is just a brief overview about the demographics that are in public housing with 1.5 million residents, 2 persons per household, 38% are disabled, 52% are white, 91% are low income, 43% are African American, 26% are Hispanic or Latino, 19% are elderly, and 36% are children. And lastly, 32% are female-headed households with children. And this is all information obtained by HUD in 2022. So now I'm going to pass it on to Dr. Kevin Lombardi, who will be going over the information for today.
Hi, everyone. Thank you for your time today, and thank you for your service to these programs and to your constituents. Very happy to have you. Today, we'll be discussing the importance of screening and digital health literacy, broadband access, and health center patients. some of the public health and epidemiological impacts that not having access to broadband has on patients and communities, list some of the screening tools to assess digital literacy, and explore how health centers can help patients with low digital health literacy. With our time remaining, I'll be opening up some question and answer time with our expert to both ask him some questions about how these programs have developed over the years and some of the impacts that improving access to digital products has had on the populations he serves, and to allow you all to ask your own questions as well. If you'd all like to introduce yourself in the chat, we'd love to hear where you're coming from and why you're joining us today. And thank you all again for your time and your service. Next, please. Just to go over some trends in digital health, we're approaching a time where technology has advanced significantly in recent years, both in terms of the types of products that are available and the integration of products and information technology. I'm sure what you've seen, Howard, over the 22 years is much more change that I've seen in my time. But having started medical school in 2013 and being here now, I can say it feels like a different world that we're in. Telehealth was a bit of a fringe subject when I first started, and people were trying to find ways to fund it and to make it happen. And today it's an integral part of our service in many parts of the country. From rural health to urban health, and from small local hospitals into academic centers. So these slides are mostly to provide you all with extra information about some of the products that are available and coming down the pipeline to contextualize some of this change and emphasize the importance of broadband access to your patients now, but also in the future. We're seeing some major trends in some specific areas that will have impacts on patients' lives going forward. And for those who do not have access to these products and don't have access to the broadband access that facilitates it, could serve to exacerbate differences in health between those who do have access and who don't. In particular, wearables and mobile health. Due to recent changes in encryption technology and the ability to share data in a HIPAA-compliant manner between Internet of Things, watches, wearables, from anything from your Apple Watch to diabetes monitors and so forth, we're reaching a time with that data is shared between objects, platforms, and health providers. So so physicians and patients will have access to this technology to both allow quicker diagnosis, better assessment of health problems, and quicker diagnosis and treatment. There are some links and some new products that are coming through and some new breakthroughs in the field here that I'd encourage you all, if you have time, to go ahead and look for. In particular, though, I wanted to emphasize the importance of both data sharing and data integration, and the use of AI in diagnosis and assisting diagnosis. With the amount of data that is available and is being shared, for example, in diabetes monitoring and blood pressure monitoring and arrhythmia monitoring, the AI facilitated diagnosis assistants allow physicians to have live data of what their patients are experiencing and be able to make diagnoses and guide treatments before they see the patient, and more effectively when we do see the patients. I know when I was practicing there was a consistent struggle to get patients to have their blood glucose levels, have their blood pressures, to keep books, to keep that information. It's confusing and it's overwhelming. The technology that's available now and will be available soon eliminates that barrier and allows providers to have better insight into what patients are experiencing and make more accurate diagnoses. And in particular, within the context of telehealth, I had the opportunity to speak with the CTO of United Health recently, and the ability of providers and patients to be in a shared digital space, a telehealth platform, and to have access to all of this data and AI-assisted tools that assist with data integration and with diagnosis will have an unprecedented impact on patient health. And unfortunately, for facilities that don't have appropriate broadband access, and for patients don't have appropriate broadband access, they will miss out on these advancements if we don't have them. On to next one, please. Some more detail on digital health and the trends, particularly in data management, electronic health records, and encryption and blockchain. A major barrier for integration of these technologies has been inappropriate and HIPAA-compliant data transfer. With the emergence of certain new encryption technologies and blockchain technologies, the future is bright as far as quick and seamless integration of data sharing. Next one, please. And some details on provider and patient acceptance of AI and emerging tech. Changes in technology impact our patients in very real ways, but that impact is limited by their ability to trust and use these technologies. As providers, it's an important part of our job is to act as diplomats for them and improve trust of the technologies and their impact. Here I've linked a variety of studies on both how patients feel about emerging technology and how providers feel about emerging technology, with some pretty clear trends here. Patients and providers are wary of new technology when they're given that information by themselves, but when it's interpreted correctly by people that they do trust, that trust increases significantly. Next slide, please. There were a couple slides here, epidemiology. Are those there as well, Fide? Excuse me, they would have been impact of broadband access on health. I can lecture them if they're not there. It would have been slide, I'm sorry, 5 on the one I sent you. It might have gotten clipped out. I'll go ahead, I have them right here. I'll go ahead and read them. To go ahead and give some information on the impact of broadband access on health and how it functions as a SDOH in many ways. Access to the internet and information technology has really redefined patient-provider relationships via telehealth and health information distribution. It's made these contacts and these interactions more efficient, and it's improved diagnosis ability and the ability of providers to track and understand their patients on a deeper level. The analog way of doing a lot of these things was in many ways unreliable. I'll point again to the clinical picture of a patient with type 2 diabetes or a patient with uncontrolled hypertension. Getting insight into those readings in a clinical interaction can be incredibly difficult. One, in particular for blood pressure and other cardiovascular factors, it's difficult to get a consistent reading. And if you're just relying on a in-person reading to diagnose your patient, sometimes it can take 2 or 3 different appointments to get enough data to be able to give that diagnosis. With new technology and the integration of these technologies into telehealth, we're able to see in a more accurate way what the patient's really experiencing without them having to make a log of what their blood pressures are, without having to worry about the accuracy of those readings, and without having to worry about the implication of inaccurately diagnosing a patient and inaccurately prescribing the medications. As such, with that change will come a disparity for patients that don't have access to these technologies, and in particular, the internet and broadband access as a foundation necessary for those technologies to build on. We could see unprecedented disparity between patients that do have access and patients that don't. As such, this is a social issue that's not only important now, but will be increasingly important in coming years. Health information distribution presents one of the most promising routes of health equity and social justice. Recent research on this subject has confirmed this relationship and the ability of internet access to mitigate the negative impacts of health inequality and inequity. Now, for those of us who work at health centers, we spend our days looking at this inequity and experiencing the very real human impacts of it. Providing our patients with access to technology, and in particular, as seeing broadband access as a foundation for that technology to be built on and for the equity to be built on that, it provides us a significant opportunity to level the playing field for our patients and to give them access to the best care we can. In particular, some recent studies have shown how important this is. A recent study from the University of Chicago linked internet access as an independent factor in both COVID-19 infections and in particular, mortality rates. And what does that tell you? Patients who have access to the internet, patients who have access to information technology are able to inform themselves more. I spent a great deal of time in the exam room educating patients. Oftentimes for patients who are from rural areas that may not have had access to the type of education as myself or others providers do, that can be a significant challenge. With these patients, we often have to build an understanding of their condition from the ground up because they have no experience with it, or they don't have the science or math education to grasp the complexities of these very complex conditions. That's a challenge to providers, and in my opinion, it's one of the areas of training that physicians don't get that much. Being able to interpret this information or health information to your population is very difficult. And as someone who's practiced in different parts of the country, I can tell you that, well, in every place I've practiced, describing a patient what his condition is different. It's different based on cultural context. It's different based on level of education. It's different based on the different demographic factors that we see in our area, be it race, be it sexual orientation, or so forth. Giving patients access to the internet allows them the ability to at least come with the foundation. And it gives them, it can act as an empowering tool as well, because patients, when they come in the exam room having educated themselves, oftentimes it increases the confidence and their ability to talk with their physicians. For those of you who work clinically, you may know that the power relationship that you feel between your patient and yourself is often very clear. It's a very clear barrier. It's something that's supported by the built environment. It's supported by even our white coats that we wear. Anything that can empower the patient to feel more equal to his provider or her provider is a step in the right direction of health equity, and broadband access is a foundational aspect of that. I say it's the most important thing since the library card in improving patient education. Health information. Anyway, oh, sorry, you don't have the slides. I'll go to the next slide. Impact of broadband access on health, just a little forward. Health-related internet use has been connected to decreased rates of depression and anxiety. Recent research has indicated that digital disenfranchisement and lack of access to broadband internet is linked to higher rates of cardiovascular disease, type 2 diabetes, and severe COVID-19 infection. And these are recent studies. And I will say that this is just the information that we know. My inclination is there are quite a few disparities in this area that we just have not studied. Just to emphasize the point that broadband access is a foundational aspect of the disparities we see in our patients and is an important driving factor of many of the difficulties we have with seeing our patients eye to eye and appropriately and quickly diagnosing. For those of you who've worked in primary care, my condolences for your schedule, because offices are busy, patients need help. The giving access to these technologies allows quicker diagnosis and fewer appointments for things, and that's efficiency, and that's better for your patients, that's better for your office, and that's better for you as the provider, for both your enjoyment of seeing your patients, your own mental health, and let's not forget the impact of burnout. If you have to see patients consistently or 2 or 3 times just to diagnose a condition, Well, technology can allow that to be done quicker, more effectively, the benefit of you and the patient. It's a classic two birds, one stone situation. My apologies for the ornithologists in the room. And I'd like to conceptualize this as an SDOH. So other social determinants of health, such as race, sexual orientation, geography, zip code, and so forth. The data is very clear on how these impact patient health outcomes, and it is severe. In fact, one of the driving outcomes, the driving factors of health. I'd like to conceptualize broadband access, and I'd like you to leave this having conceptualized broadband access as a social determinant of health. And that's not just my opinion. Data and research in this area has showed that broadband access to the internet has as much, if not more, impact on a patient's health than many other factors that are social determinants of health. If there's one thing you walk away from my slides, I hope it's that. And I think we can pass on to Howard's slides now, Fide, if you don't mind.
All right. Thank you, Dr. Lombardi. Again, I would like to start, if you want to go to the next slide, I'd like to start by just saying, one, that, we're excited here because we're seeing a lot more of the utility companies coming out and stringing the wires, and they're hanging on the pole for the most part. We don't know when they'll get to actually installing those and moving them into the homes. And we're somewhat skeptical of that because probably 15 years ago, we're in a region where the Virginia Tobacco Commission took the tobacco settlement money and actually put fiber along all the major highways in the Tobacco Commission's region. That was never communicated to any community, and a lot of those actually are being covered up now with the new systems going in. And so we never saw that happen. We're a lot more excited now with the federal support for broadband, and hopefully see that come into the homes. It is a great advantage for those in healthcare. A little bit about Tri-Area Community Health. It's a 5-site FQHC serving Carroll, Floyd, Franklin, Grayson, and Patrick counties. And we're located in the Blue Ridge Mountains of Virginia. Actually, the highest mountain ranges in Virginia are right here in our service area. And we just bought a building and be adding a new site in January. So it'll actually be 6 at that point in time, and it's in Grayson County as well. We will have, with the Grayson County site, we'll actually have 3 full-time service retail pharmacies. This area is part of the economically depressed Appalachian region. So, poverty is probably one of the biggest social determinants too that you can run across. So, that's part of the issues we deal with here in this area. Tri-Area serves around 10,000 patients a year. We hope maybe the new site will bring that up a little bit, but about 35,000 patient visits. We've actually had a little increase in our number of employees. It's probably about 130 now. It's probably about 25 medical and behavioral health providers that we employ through Tri-Area. Tri-Area is NCQA level 3 recognized as a patient-centered medical home. Next slide. Just to give you an idea of our service area, pretty much the line below the dark blue down there is state of North Carolina. Actually, Interstate 77 going down to Charlotte, North Carolina runs more or less in sort of that western end of that section. And if you get just a little above us, it's West Virginia. So our service area is basically from Roanoke westward to just past the Interstate 77 line. So, and again, as you guys may know, the darker blues where 75% of our patient base come from. The other lighter blue is where you pull 25% of your patients from. Next slide. And these are the 5 sites we have, plus our corporate site. We're going into Freeze Community in Grayson County, and that'll be an additional site that we'll be adding next month. So, next slide. One of the things that we were able to do is the National Association of Community Health Centers and the National Consortium for Telehealth Resource Centers had a publication out in 2021 that listed the community health centers with telehealth promising practices, and Tri-Area was noted as one of those. And it's primarily, next slide, it's primarily due to a diabetes quality improvement program that we had. It focuses on uncontrolled diabetics, and what we selected was diabetics with a hemoglobin A1C of 8 or greater. We have access to an endocrinologist that is through the University of Virginia, and he follows those patients for 6 months through telemedicine and doing some on-site visits at Tri-Area. But it's a real intense self-management program during those 6 months. And this guy's phenomenal. He actually talked Nutrisystem into giving them the 3 meals a day for the 6-month period. So he's quite a go-getter to get things like that done. It couples certified diabetes education classes, digital retinopathy screenings, which we have at probably all but maybe 2 of our sites now, and we'll work to try to get those in place. University of Virginia actually reads those for us and gets the results back timely. We use home monitoring, glucose measuring device. It's actually a Dexcom meter, and we measure the dietary intake, the physical activity for the patient. All that's uploaded through a smartphone, and the Dexcom meter sends the signal to a smartphone. And due to lack of broadband access and Wi-Fi in the area, when they actually hit a cell tower, if they got it in their purse or carrying their phone with them, it'll upload when they hit that Wi-Fi signal. So it's not real time. That's what we were hoping for, was real time. But due to lack of broadband in the area, it's actually more so at frequencies when they hit that cell tower, and everything, all the information and data uploads and graphs in a secure cloud. That can be seen by the endocrinologist. It can be seen by the patient. Our Tri-Area providers, nurses, and case managers all have access to that cloud with secure password clearance. Next slide. Dr. Santon's been really successful at working this program. As a matter of fact, through the patients that completed that 6-month program under Dr. Santon, they come in with a hemoglobin A1C of 9.9, and at the end of the 6 months, it was reduced to a 7.7, so 2.2 points in a 6-month period, and that's pretty dramatic for a diabetic patient. Greatly improves their quality of life. And next slide. FCC Commissioner Brandon Carr actually done a press conference at our Tri-Area Laurel Fork site in June of 2019 to announce the $100 million Connected Care pilot grant. He said he didn't want to do that in Washington, D.C. He wanted to do it out in a rural community where it actually had been proven to have some success. And they called and asked if we'd do it, host them at Laurel Fork, and we graciously accepted that. We brought a lot of recognition to the diabetes program, and so we're grateful that he did want to get out in the rural community and see that done. So, and next slide. The types of telemedicine and telehealth used, synchronous or the live and real time. We have access to 24 specialties through the University of Virginia, and through their charity program, they actually accept and offer those services at a sliding fee program to our uninsured patients. So there's no problem with getting uninsured patients covered. They provide there's provider and staff CME services through that. They do patient education, the certified diabetes classes, or we can do those in our center. Whereas some of the hospitals in this region have charged from $30 to $80 per class to do that. So again, it reduces the travel burden for these patients. Plus, again, they're not looking to have to pay that $30 or that $80 for somebody that can't afford their medications. We have a diabetes improvement, quality improvement plan. And we have site-to-site consults that we can do through our Tri-Area providers. And that's especially important for some of the behavioral health providers. We have a part-time psychiatrist who works for us, psych nurse practitioner, several clinical psychologists, LCSWs, LPCs. And again, if it's something that's a little above their head, they can reach out to one of the other behavioral health providers at one of the other sites. The asynchronous or the store and forward, we have an agreement with the University of Virginia and the radiology department, and we transfer our digital x-rays to them. We get the results by the next day. Before we actually had this in place, it's probably taken 2 weeks to get those x-ray reports back. So we get them the next day. We actually have a process where we can get a stat reading for anything that may be an emergency. You're not certain whether it's a break, something that needs to be sent on, or something you can just wrap and you know, treat the patient and send them on. So again, it's a great benefit for somebody out in a rural community. The digital retinopathy screenings, again, we have these at about all of our sites. I think there may be 2 that we don't have now. But again, when we first started doing this, there was about 40% of the patients said that's the first one they'd ever had. So again, they were non-compliant on part of their recommended treatment. The actual physician at UVA that does those interpretations and gets that back to us, he went through an FDA approval to be able to use his iPhone and our iPad and smartphone to try to get those results back to us within 20 minutes. So that, again, we could make the referral for a patient if they needed that while they were still in their building, didn't have to do the follow-up. Next slide. These are the 24 specialties that we have access to through the University of Virginia. And again, all of these pretty much at some kind of a discounted fee for indigent patients that can't afford to pay for them. Next slide. The benefits for this type of approach for a community health center, it removes a lot of the rural isolation for physicians and makes it easier to recruit and retain. It puts the resources of a major university right at their fingertips with the access to do that through their laptop or through their computer. It improves compliance with the patient-centered medical home conditions and standards. It improves patient access to specialty care. It improves patient compliance with treatment plans, and it improves the coordination of care. Next slide. You know, some of the changes that I've seen, and you know, again, in the past 20 years with this, when we first looked at putting one of those carts in our practice, it was about $75,000. And they did have a couple other things like a stethoscope that, when our nurse or the person using that equipment heard the heartbeat, they heard it in Charlottesville at the same time. And, you know, and those type devices you can still buy, but basic equipment, I think the last ones we bought for the cart was about $10,000. So its price has come down significantly. You have to have good connectivity, 20 by 25 megabits per second or greater. And a little further here, we'll talk about what ours is now. We've seen some improvement in that, but it's still not what it needs to be. UVA has the capacity of being able to reserve space on our server so that, again, if we're doing a telehealth consult, we don't get pumped off because the space is required somewhere else. They train staff. Their certification programs like the STAR. UVA offers several certification programs for a provider that may be doing a telehealth visit. And you really need a provider champion if you're going to see a successful telehealth program. When I come to Tri-Area about 11 and a half years ago, they had equipment, but it's all outdated. It's still the old analog type systems, wouldn't connect to anything. So one of the first things I done was actually sought grant funding to get telemedicine back up and running at all the sites. And it never really took off until we got an interested physician that would do it. And then I tell you, a lot of our growth has been attributed to Dr. Satin and that diabetes improvement program. And that sort of sparked that. And telehealth is a big part of what we do right now. So next slide. The telehealth resource centers, I think there are 14 of these across the United States, plus the National Center. And again, they're excellent resource for providing education to organizations and individuals that may be interested in telemedicine or telehealth and those technologies. They can link you interested providers with healthcare facilities and programs and successful programs that are using telemedicine. They provide technical assistance and arrange for trainings and get programs up and running. They work to identify targeted regional needs in service areas. I have a great working relationship with the director for the Mid-Atlantic Telehealth Resource Center, Kathy Weberly, and her staff. And again, they've referred people to me that were interested in telemedicine, telehealth, and they've actually put me on a FQHC focused work group that deals with issues and problems that they may be having around telemedicine. Would also encourage you to look at what state organizations you guys may have. We've got one called the Virginia Telehealth Network, and I've been a member of that since probably back in sometime in the early 2000s. But again, they deal with things more on a state-wide basis. And great, again, you're only as good as what the state regulations allow you to do. And that group works a lot with policies and issues and things. Next slide. CMS and their definition in the Congressional Federal Register, volume 79, number 91 from back in 2014. And they refer to service as a distance site, and their term is physician or practitioner. Now the reason, and we have issues is being able to be a distance site as an FQHC, because our CMS provider status is as a federally qualified health center, and rural health clinics have the same thing as an RHC. And neither one of those say physician or practitioner. So again, we're been able to be reimbursed under the executive order and the emergency order while we were dealing with the COVID. But once that order is lifted, we'll have 120 days. And then whether we actually get paid by Medicare or not will be determined by doing that. So we still got some work and some issues to make certain our Congress knows that, you know, this is probably more of an advantage in a rural area than it is anywhere else. But again, as an FQHC, we potentially will not be reimbursed for Medicare efforts. And many commercial insurance and carriers default to whatever the CMS policy is. So again, it'll affect some of the carriers and things that may recognize and reimburse you for telemedicine, telehealth. Even HRSA back in 2018 only covered you for behavioral health visits. Never got any credit for anything you were doing medical wise, and they changed that in 2019. So that's a fairly recent thing too. Next slide. Telemedicine and state regulations, again, you're only authorized to do what it comes down to on a state level. And in Virginia, telemedicine, or everywhere, telemedicine is defined as the use of technology to diagnose, monitor, and treat patients. Telehealth is applying technology to assist patients in the management of their illness and self-management to education and support systems. And again, our diabetes program is an ideal case to point to in how beneficial that can be. Synchronous telemedicine is actually real-time. It's interactive audio and video. Asynchronous is, again, it's a store and forward where you're transferring an image or other data. Next slide. The Virginia telehealth regulations, the parity law that they passed, and I think this was back in 2012 or something like that. It mandates the equivalent coverage for a telemedicine in-person as the same as an in-person visit. And again, you got to realize that that's got to be live and interactive video for that to occur. And they require that for private payers, for Medicaid, for state employee health plans. State mandates that reimbursement only for Medicaid services provided via live video, and provide limited coverage for the other telehealth applications. Tri-Area is paid for telemedicine services, even as a distance site through our state Medicaid program and most commercial carriers. Next slide. Some of the issues we still deal with are poor connectivity and broadband in rural Southwest Virginia. Currently, we have about 50 megabits per second at Laurel Fork and our Grayson County sites, 100 megabits per second at our Floyd site, and 20 megabits per second at the other sites in our corporate office. I've got 200 megabits per second here in my house. So again, it depends on where you live with some of these access issues. 2 years ago, we had 10 megabits per second at Laurel Fork, 6 megabits per second at our Floyd site, 3 megabits per second at Ferrum and our corporate office. So you can see that's changed drastically over the past couple of years, and we really look for some significant increases as the broadband becomes more available. You know, and not only that broadband bandwidth, it's competing with our EMR, our practice management system, our email, and our internet in our office. So you know, so you got to take all those into consideration too. Next slide. From the digital health literacy, one of the things we thought we could look at and monitor are the number of patients with access to smartphones and other devices that actually use our patient portal. And you know, we can put their visits in there, we can put their test results in there, the results of their last visit, and they can access through their own digital device. We had our IT guy to give us a report on that, and in 2019, we had 7,094 logins. In 2020, we had 14,280 logins. In 2021, we had 23,000, almost 24,000 logins. So we more than tripled the number of patients that are actually using that patient portal. You know, Tri-Area staff and Dr. Santon have helped access and with access and knowledge for the patients to be able to use that. And so we very much appreciate, again, the efforts that he's brought to our organization. Next slide. Screening for digital health literacy and broadband access. We have some tech checks. We have a new telehealth coordinator that started in 2022. And she actually works with first-time telehealth patients to be sure they understand and have appropriate equipment and broadband with. She also provides any provided devices that usually the UVA does a lot of those with sending tablets out, and we do some of that at Tri-Area, but they're usually restricted and they're locked, so you can't use it for just surfing the internet and different things. It's for a particular use and purpose, and you know, so they also go over some of the etiquette that you know we discussed with the patient. You know, no kids playing in the background or no TV, not connecting at McDonald's and trying to have a secure connection and things. Ingenium assist with analysis, integration, and operational in some areas, and the UVA team assists patients with any device that they supply to make certain that they understand it and have adequate connectivity. All the Virginia Community Health Centers have eClinicalWorks as their EMR system. UVA, you know, they have their system, and again, and I think it's Epic, but for the ability for those there are some software programs that if it's a certified program, HIE program, they will actually provide a readable format for those two systems to collect that data from one and put it out in a readable format. In our area, we have a low patient portal systems and access, but you know, part of what we've seen is now some of the Medicaid programs, some of the Medicare programs are actually giving patients a smartphone. So again, that's helped those efforts a whole lot. But the other thing is there's two different, we use pretty much a system for our patient portal, Hilo as our patient portal system. But we're working with UVA on a couple of things now, and some of the population, patient population information that need to be collected. And we're looking at the I2I system. And basically we've gotten two new HRSA grants through UVA. One will focus on chronic disease management, and that's cardiovascular disease. And the other is with the UVA Cancer Center and Central Virginia Health Services, which is another FQHC in Central Virginia, and Tri-Area included as a partner, but it'll be to do advanced cancer screenings for colorectal cancer, cervical cancer, and breast cancer screenings. Next slide. I think let's see, the STAR program training that's offered through a community or a college down in near the Danville area, Martinsville actually, and so they offer that. We send usually our nurses or people that may be working the equipment, doing the vital signs and things on our end. UVA offers some trainings by discipline for the medical providers to prepare them to do and conduct a telehealth visit. UVAs are online trainings. The ones offered by the New College Institute in Martinsville actually require you to be on site at least one evening a week. And they provide a good orientation of the device and the equipment and the use of telehealth. And, you know, from standpoint too, they can troubleshoot for any problems or things that go through there. Next slide. This is my contact information. If you have anything, you feel free to contact me by any of these sources. And again, appreciate your time.
Thank you, Howard. Still not getting a hold of that mute button after these years doing this. I just wanted to make a couple of comments on the things that you mentioned before we open to questions. And if you look at the bottom of the screen, right next to the Q&A tab, there's a hand. At this point, if any of you have a question or would like to ask either myself, Howard, or Pete a question, please raise your hand, and when we see that, we'll grab you. But I just wanted to make a couple of comments. One about I was noticing the graph, and you mentioned this in past conversations we've had, Howard, about that A1C change. 9.9 to 7.7. I need to emphasize to everyone what a big change that is. A1C is a logarithmic number, so that's an exponential difference, and that's a big difference in patient care. I had the privilege of completing my residency at Danville Regional Medical Center, which is right next to Howard's area in Southern Virginia. And bringing specialists to our area was a consistent challenge. And it was a challenge that had greater impacts than some would think on our service area. One, we just didn't have the people. We couldn't get them down there. The ones that we did have, the system needed to pay quite a lot of money to get them down in the area. They needed to pay them to relocate, and they needed to pay them to incentivize to move them from wherever they were elsewhere in the country to our area. Now the issue with that is endocrinologists are specialists that receive not just residency training, but 3 years of specialist training. And the vast majority of those programs are not in rural areas. In fact, they're not anywhere close to them. They're primarily in the Northeast and the West Coast. And that's where the physicians tend to stay because that's when they tend to train. So bringing those physicians in is expensive, it's difficult, and those are significant barriers to care. Telemedicine and a program such as this provides an opportunity to vault over those barriers and provide patients with access that they just did not have. And it's a benefit to the financial health of the organizations because they know if this is an available technology, it takes away a financial barrier of having to get a needed specialist there. And these metrics, A1C, diabetes health, how health systems manage these and the results they get have very real implications for the financial health of the organizations. So I just wanted to emphasize that. I did want to say that the difference in 75,000 to 10,000 reminds me of my parents talking about how expensive VCRs were back in the day. To the provider champions, you mentioned that it's important to have a provider champion for a program like this. And I just wanted to emphasize that point, not only in telemedicine program, but in any program that you're implementing into your health center. It can be difficult to follow through. Health centers have a lot of things going on. Making sure you assign an interested and knowledgeable person to being that point of contact, being the person who's organizing that and taking accountability for that is a critical aspect of this. And I just wanted to emphasize that. And that's not just my opinion. There's plenty of data to support that. One thing that was clear to me early on when we were talking is the importance of relationships with outside organizations. You've mentioned the University of Virginia in particular. They have access to some of the best medical specialists in the country. That I can't emphasize enough how important that is, that relationship, those relationships like that exist. I was wondering if you could speak to how you started that relationship and how you've grown it since then.
I'd be glad to. Actually, somebody asked me, the telemedicine is actually just getting started and everything. And the medical director for the University of Virginia's telemedicine program is Dr. Karen Ruban. And so got connected to Dr. Ruban. And in 2003, she actually talked me into testifying before Congress for the benefits of distance learning and telemedicine. And so she was on the panel, I was on the panel. They had somebody from Texas and I think somebody from up in maybe Boston or somewhere up in there. But again, that was pretty much to fund telemedicine and telehealth across the country through actually it was through USDA. So again, I've maintained that relationship with Dr. Ruban. We meet on a regular basis. The 2 UVA grants that we just got, Dr. Ruban is very much involved in doing those. The one on the cancer screening, advanced cancer screening, there was only 11 of those awarded nationwide. And Central Virginia and Tri-Area worked together and applied through a collaborative effort. But there was another community health center called, it's Blue Ridge Health Center on up near the Charlottesville area, and they got funded too. So again, 2 of the 11 that were funded nationwide come to Virginia. And all of that, I think, is attributed to UVA's efforts. But again, partnering with other FQHCs and other organizations. As a grant writer, I've always thought the more broader net you cast, the more people you can bring into it, it improves your chances of funding.
So Howard, would you have any recommendations for those who are at health centers today who are looking to expand their relationships? Would you have any recommendations on how to do that?
Yeah, like I say, I think if you get involved with, and we try to do it for everything. In parts of our service area, like Patrick County lost a critical access hospital in 2017. In 2018, they formed a group called the Healthy Patrick County Coalition. And I've been asked to serve, I was asked to serve on that board from 2018 and until we're still doing that. But like I say, it doesn't take much to get out and get involved. I've been involved in a couple of health workforce issues that again bring a lot of other private providers, some other FQHCs, behavioral health, dental providers and things. You just got to be out and be part of the community in order to see a lot of those things happen. And after all, our program's a community health center. And again, community is an important aspect of that. And like I say, taking part in those activities and taking part with the partners around you. I spent a good deal of time yesterday talking to, it's a free clinic, and they were looking to add a dental operation, and they wanted to know how they could do that best. And they're typically one that has not billed for Medicaid or anything like that. So we spent some time talking to them about that type approach. But again, just get out and get involved in your community. And I'll tell you, one of the lessons I learned when we talked about that provider, having that provider champion, 20 years ago, I was in a program that was sponsored by, is an NIH program, but HRSA and Public Health Service had a lot of, and it is actually a chronic disease management program called the Health Disparities Collaborative. And they actually recommended a full team. It was that provider champion. It was some leader from your clerical side, maybe a nurse manager or something like that. It was somebody like an office manager or somebody from your clinical staff, but it's also somebody from senior management, a CEO or somebody that can actually have the opportunity to divert and put resources in to support programs you got started. And that Health Disparities Collaborative was amazing too. I know the organization I was with then, we got our hemoglobin A1C for the patients we run through that program down to a 7.3, and was asked to be a presenter at one of those national congresses or conferences that they would have. And somebody said, I thought you were from back in the sticks. And I said, I am from back in the sticks. But you know, what we've done, we've created some great partnerships through things like the University of Virginia that bring us to specialty care and some of the other things that we need, the digital retinopathy cameras. But you know, we got some local grants to be able to buy the glucose meters, some of the insulin and some of the medications that they needed through a foundation, local foundation here in Virginia that supplied a lot of that. So those partnerships are important if you're in a small rural area and a community. Don't compete, collaborate with the people that are out there.
I think that's a poignant point, Howard. As you're saying that, I couldn't help to think, we're talking about technology here. We're talking about a foundational technology that can help, that we can build other technologies on to help our patients. But the way that's built is very analog. It's by talking to people. It's by getting out in your community. So I think that's a point that's worth emphasizing, is that building those relationships to get that technology is the old-fashioned way. And having had the privilege to train at community health centers and having seen quite a few of them since starting in this role, there are a few places that know their community as well as community health centers. So that's an asset you all can leverage to make those relationships and to build more for your constituents. Now we're up against time now. I wanted to thank you all for your service to your patients and to your communities, for your time here, and wish you all happy holidays and safe travels. And if there are any pressing questions that need to stay, I'll stay on a minute. Just make sure you put your hands up so I don't leave before you need me. And otherwise, thank you all for your time. And hope to see you at future webinars. And thank you, Howard, for your participation, and for VDay for facilitating everything today. Thank you.
Thank you.
Yeah.
Thank you, Howard. Thank you,
Thank
Kevin.
you for allowing me to be part of it. And if you will, can you send me the slide decks and the presentations you've done today?
Yes.
All right. Thanks, guys. If I can ever help out, let me know.
Yes, sir. Thank you. I'm going to give you a call, VDay, if that's okay.